So this is kind of a new session that we dreamed up this year to really get input from vascular neurologists, acute care practitioners like Dr. Alexandrov and our interventional colleagues. So I'm just going to click through this. This is really get the audience involved. There's some cases, and then our moderators are just going to make our experts give us their expert opinion and comment on your opinion. So, and we may not get through all of these, but here's the first case. And some of these are out of the box a little bit. They're not your standard thrombectomy cases. So here's your first picture of this patient that we receive. Oh, sorry. I'm going to go back for a second. It didn't show you the history here, but this is a patient who, that MRI is about 24 hours old from an outside hospital. The patient has an NIH stroke scale of 24, is aphasic, is hemiplegic, has a left MCA syndrome, and that's the CTA that's available to review, which at least, in full disclosure, these are my cases. So you can criticize me as well. The patient has a high-grade stenosis of the left superior division of the middle cerebral artery. At least that's how I was reading this. So the first question for the audience. I'm starting to get some different varied responses. Someone from Stanford just answered because I just saw MRI. Okay, so if we could get our experts to comment, what do they think? What would they do?
Take the lead?
Oh, sure. So it's relatively acute. This is the patient's been in the hospital, I guess, 24 hours, or this is their acute presentation?
That's a 24-hour MRI after the symptoms started.
Okay. I think that, you probably I would get a CT perfusion, but I think with the diffusion being there, you kind of already have an estimate of the core, and if the stroke scale is that high and the patient's aphasic, I think you can, sort of see that you have a clinical core mismatch at that point, and so. It may be reasonable to make decisions based on the imaging you already have and select no additional imaging, but I would probably get perfusion imaging.
Do all the experts agree that perfusion imaging is the next step? So Tom taught me everything I know about stroke, so Tom, can you?
I think either that or no imaging.
Okay.
I think you can sort of predict what you may or may not do at this point.
So there's no imaging study since that MRI 24 hours ago?
They're sending us the patient. They want to know, I want to know what you guys would do. Then we can compare it to what I did.
I mean, if there's no imaging from 24 hours ago, I might just repeat a CT brain just to make sure there's no interval change.
Okay. So, this is what I did, because I kind of agreed with Joanna. There was a clinical mismatch to the diffusion, and I didn't know what I was going to see next, frankly. That's the follow-up MRI, and now it's been, I don't remember how many hours, but this is more than a day after the onset of the patient's symptoms. So, another question, what's your next management step? I don't think oh, good. So. A lot of people voting. All right, well, we can get everybody talking. Ann, I'm curious, what would you do? What do you want us to do?
Would it make a difference?
Well, I mean, I don't know if it would make a difference or not based on what you're showing us, but I don't think that there's necessarily a call for induced hypertension in this patient. I would probably stay away from that.
Okay. But 34% of people thought we should do all of the above, including induced hypertension, but maybe,
What is the blood pressure?
so it was actually remarkably high when she arrived.
Okay, well, I'm definitely not doing a damn thing to it.
Yeah, I mean, I think at this point, it's not unreasonable to consider an intervention, but not necessarily because of the acute setting. This may be, this has now become sort of little bit semi-subacute. And I think the more careful you are with the physiology of this patient, the better.
Okay.
So the DWI lesions would suggest there's some progression, even within 24 hours. Maybe that's part of the natural history, but the lesions are slightly expanding.
Yeah, so do you think there's still a clinical DWI mismatch? Because that's what I was trying to figure out.
Well, you begin to see a little bit of hypodensity too there. I mean, it looks a little bit MCA-ish, but it's a better scan, I think.
I think I'm the only radiologist. I would say there's no significant difference.
Can you speak into the mic, make sure everybody hears what you're saying?
As the radiologist here, I'd say there's no difference, and you could do whatever you want on that list as long as it includes angiography and intervention.
So I'm a neurologist, but I agreed with you, Gary. So that's my picture, or movie, actually, so you can see the flow. Can we play that movie again, just so the audience can see that? And the lateral picture as well.
Yeah. Well, the stroke scale are 20, so. But yeah, in my practice, these are when you're off the guidelines, the further off you are, the more of the imaging supports you get to kind of create your argument. So we would typically get a CT perfusion, and I'm sure there would be a great mismatch.
Yeah, that's what I was suggesting, that it's likely that you would proceed, but the getting the CT perfusion is what I would do, just to have more evidence to back what you're doing, because I think you would see a big mismatch, and you're 24 hours out, so you're within the acute kind of phase of the patient's symptoms and acute elbow treatment.
All right, so we've kind of asked this question a lot, and that was what was in front of me, I thought, in this case. So yeah, everybody agrees now. So show you the diagnostic angiography. It's good fidelity with the CTA, I thought, which was nice. We try to hammer home in our spoke hospitals that everybody gets a CTA when they're as sick as this patient was on presentation.
One other question could be, is this a recanalized embolus? I think,
Okay, well, that goes to this poll right here. What are you going to do with this now? So, Tom, while people are voting, if it's a recanalized embolus, how would you treat it, if that's what your decision is based on looking at the angiogram? And this is Tom Wolf, not Tom Kent.
Yes.
Sorry, there's two Toms up there.
Well, the more proximal vasculature looked pretty normal. So, depending on baseline risk factors, which, theoretically, if this was an embolus, you may still be able to do a thrombectomy, a stent retriever, and maybe get that out of there. And even with the baseline angiogram, confirm that there's a perfusion defect. There's slowing in all of those distal branches, so the transit was different and would help confirm what a non-invasive perfusion scan would tell us. But certainly considering a thrombectomy pass could be an option if there were no athero risk factors and we didn't have, especially if there was an AFib or we knew past medical history on the patient.
What does the rest of the panel think about the audience's votes? They're still coming in. I like
Can
the.
you go back to the angiogram?
Yeah, let's see if we can do that. There you go.
I think, as you said, it is a reproduction of the CTA that was done several hours before. It looks very geometric to me. It doesn't look that fluffy. Yes, there may be thrombus on it because, again, why did this patient present?
Speak into the mic a little bit. Yeah.
Okay. You know, so what was the cause? If this is a chronic stenosis, why did the patient present it? It's chronic. So there may be dissection into the thrombus. There may be an abraded surface that's accumulating thrombus. But I would say I would give it a go with balloon angioplasty to see its nature. And I get very concerned when I have to pull across a lesion that's more distal towards an M2 and then have to give antiplatelet agents after I put in a stent that they're going to bleed from some perforators that have been traumatized. So I would rather get something done simply without tugging if I'm going to use antiplatelet agents.
You mentioned balloon angioplasty. It's a relatively distal lesion. What do you think about angioplasty in an M2?
It's not that far.
Yeah, it's big.
Yeah, distal is relative.
Yeah.
Tom, Kent, you have a lot of experience and taught me a lot about drugs like ReaPro and Integralin. Can you comment on whether that's appropriate in this situation?
Yeah, I think it probably isn't because if it's been going on that long, you've established your bridges, your fibrin, and so I don't think you're going to do that much. I think reocclusion is really the best place for those kind of agents. So I have to agree with Gary's approach at this point.
Okay. Any other comments? Anne?
Hey, this decision's beyond my paycheck.
Like I said before, you're never short for opinions, so I thought I should at least ask.
I think it's if I had going back before,
Yeah.
if the patient's at another hospital and we're transferring, in this kind of case where I think we're going to transfer, might need to put a stent, and the patient hasn't necessarily gotten TPA, right? I may have asked them to load the patient on aspirin and Plavix before the transfer and before the angiogram, knowing that you're going to have to go in and you might potentially put a stent in. If you don't have to put a stent in, they need to be on antiplatelets anyway. The diffusion burden isn't that large. I don't see a big downside of having them on dual antiplatelets a little earlier. If you have the time to load it, take advantage of it.
Okay. Well, so this is what we decided to do as a team approach. I sent the diagnostic angiography images to one of my partners because this is probably the most rare acute stroke procedure I will do, very rarely. And we kind of had that feeling that, yes, this was flow failure, the patient's symptomatic, and this is a patient who there's a mismatch between the clinical scenario. But then the next question is, well, what do we do with the blood pressure? So can the panel address that?
So I guess this is where I feel
Yes,
more comfortable
please.
chiming in.
Yes.
You know, you look at Dr. Mystery's nice paper, and it's clear that you want to go down, and that's always been kind of our bias anyway in Memphis. We oftentimes will say get it below 140/90. I mean, I have to admit, none of us really know what the best target is, but I do think that you have to keep things in perspective with what we know about the parameters that we have, you know, at 180/105. And in fact, I'm a bit shocked that we even still have 180/105 because there was a paper after the NINDS RTPA stroke study with a secondary analysis of blood pressure in the trial showing that if your systolic was above 175 and your diastolic was above 100, your risk of an SICH was quite significant. But for some reason, we keep falling back to that 180/105 parameter. But wherever we go, we would definitely dive them down, probably advocating for about 140/90 or less.
And so the next question is, how long are you going to do that for? This is the patient's response to therapy. At 24 hours at NIH is actually 12. It's significantly better, but she's not perfect by any stretch.
What happened to the blood pressure post-stenting? What
So
happened?
it went down significantly right away. We didn't have to do very much, but we're still grappling with how long to control blood pressure aggressively. Is there a risk for hyperperfusion in this situation? So, Tom, what would you do? What would you guys do in Boston?
Well, I would just throw in more of my opinion, which is
Yes,
that
please.
Once you go down, why would you ever go back up, especially if you've got ischemic tissue up there and, fragile vasculature traveling through that ischemic tissue. It doesn't make sense to me to ever go back up, and I would prefer that, based on the characteristics of the patients and other comorbid diseases, that if the patient can swallow, get them started on other meds alongside a dihydropyridine calcium channel blocker like either nicardipine or clevidipine. But I don't think that you should ever let them go up. And in fact, it's when we lose track of that first 24 hours and suddenly patient's pressure shoots up and we're still inside that SICH window of 36 hours that we get ourselves in trouble.
Yeah, I agree. I would be very nervous about reperfusion hemorrhage, just like a carotid lesion that you open up acutely. And I would talk to the anesthesiologist, say, I want the blood pressure, less than 130/80, and I want you to use whatever drug you need, and I want it to be maintained through all the transitions of care from the stent post-procedure to the ICU for 24 to 48 hours. So I think a conversation with the anesthesiologist is really key here, because if you don't control it, the blood pressure can really go awry, and you can have a complication. I had a patient die on me in fellowship.
Just curious, what did you do with the antiplatelets in this case?
So I didn't know what I was going to do with the patient up front until I kind of saw the angiographic images, and it was that kind of carbon copy of the CTA, and we made the decision to stent. So the patient was heparinized and given rectal aspirin and put on an integralin drip with about a quarter loading dose, and then half of the cardiac infusion continuous. And then we repeated a CAT scan about 2 hours after the procedure. Because integralin I can just turn off. If I load the patient with Plavix, or even, and actually in most of these acute cases, for whatever indication is use Brilinta, I can't take that away once it's done. So I want to see some modicum of stability, and once we did that, we gave Brilinta 2 hours later, the integralin is off.
I'm just curious if anyone has started using Cangrelor. We just recently brought this into our lab for these specific kind of cases just because of the fast onset, fast off action. It's very expensive, so it was a bit of an ordeal to get the pharmacy to let us have it, but just curious if anyone else has experience with it.
We don't.
Cost has been the main limitation.
Yeah.
It's
I'll
the
typically run the integralin for overnight, get a CT the next morning, make sure there's no hemorrhagic things, and then transition.
Alex has a question in the audience.
Yeah, well, I had a question about your comment about Cangrelor. The concern with Cangrelor is that it results in very rapid and nearly complete platelet inhibition. And if you measure platelet aggregation, the first 2 patients I treated, even though I used 30% of the cardiac dosage, had 0 P2Y12 function. So I'm very wary about using Cangrelor because of that, and actually both those patients had hemorrhage. But getting back to your question about the blood pressure, I don't think this is that difficult, right? I mean, we know hyperperfusion, we know the kinds of patients it happens in. We had a series in Cleveland, 850 consecutive carotid stent patients. We initiated an intensive blood pressure protocol, and in those patients who are high risk for hyperperfusion syndrome, critical long-standing stenosis, symptomatic hypertensive at baseline, we were able to reduce the clinical incidence of hyperperfusion syndrome from 37% to less than 1% with an aggressive blood pressure lowering protocol less than 120. And, you know, and I think of this very simplistically. If they have ischemia, I can potentially fix it. If they have a hemorrhage, ain't no one going to fix it. And we know the #1 risk factor for intracranial hemorrhage, spontaneous or otherwise, is hypertension. So it's a pretty simple calculus in my mind. But obviously, no, we don't have prospective randomized data to support that.
Thank you, Alex. We're running a bit behind on time. Should we move on to the next case?
Yeah, I think we should probably move on to the live cases at this point. So thank you, panelists, for indulging this idea and for this multidisciplinary discussion.